protect, et cetera, et cetera, et cetera, et cetera. One of the things we forget about is that first tenet, do no harm, right? And the most important thing that we can do is not hurt our patient. More important than treating the patient is to not hurt that patient. And that's the reason it's worded that way. And sometimes we just kind of glaze over that. First, do no harm. Okay, yeah, whatever. And it's so important to remember that part because it's our job to protect the patient 100% of the time. Like that's our full-time job is to protect the patient. Just to kind of bring the mood up just a little bit, one of the things that I always thought was kind of funny that people used to ask me what I did as a hospital pharmacist. I don't know if you've done this yet. Have you tried to explain to your non-healthcare workers what you do for a living? Do they get it? Anybody know somebody that understands what you're going to do as a pharmacist? Nobody, right? Yeah, we're horrible at that. And so I finally feel like I came up with something that was really good whenever I was a hospital pharmacist. And I worked in the ICU. And instead of going down the usual direct patient care, there's the buzzwords that just kind of make other people glaze over. And I finally came up with something. And it was, they asked, why is a pharmacist in a critical care unit? I don't understand that. And I said, well, think of it this way. Nurses and doctors make patients better. I keep nurses and doctors from hurting patients. Not like any of those people go to work and say, I want to hurt somebody. Nobody does. Hopefully nobody does that. I'm sure there's that 1 in a million person that really needs to not be involved in life. But we don't go to work and say, you know what? I'm going to hurt somebody. We don't do that, right? I mean, y'all have heard that before, I'm sure, and I don't want to beleaguer it. But hopefully that kind of gives you a grasp of why we talk about patient safety. So y'all seen the Swiss cheese model before? Is this familiar or not familiar? A little bit familiar? Okay. So basically the idea is that the Swiss cheese model assumes that we have processes in place, processes designed to protect patients from harm. And some of those are people-based, some of those are technology-based. And actually the recorded session for tomorrow, which you just need to listen to sometime between now and the next session, that session for tomorrow really talks about these slices of Swiss cheese, okay? But what I want you to get just from this algorithm is the idea that what happens is, even in the most robust systems, the more slices of cheese you have, obviously the less likely that arrow is to go through the hole all the way from one end to the other. But it can still do it. And so we try and build these processes, but sometimes human factors just defeat the process. When we talk about harm, the harm I just described obviously is the top row here, death. So scale of harm. So there's death at the time of assessment. In other words, you recognize an event. Where is the patient in that moment? Okay. Severe harm. So that's going to be bodily or psychological injury. This includes pain, disfigurement that interferes significantly with functional ability or quality of life. In other words, we hurt them long term. Moderate harm is just kind of a step down from that. Same kind of concept, but not as severe. As you might imagine, the difference between severe and moderate harm gets a little gray. Okay. Mild harm, so we have minimal symptoms or loss of function. You have injury limited to additional treatment, monitoring, and or length of stay. So in other words, a good example of this is they're in a hospital and they, like we do something that causes us to have to monitor additionally. Like we have to draw an extra lab, or we have to do something mild like that. Or maybe they have a fall and it's just some cuts and bruises, not a broken leg or anything. We mend that. Or something else along those lines. No harm, the event happened, but we got lucky. The event happened and no harm befell the patient. Okay? Usually we wait a little bit before we differentiate between the mild harm and no harm to see if something is going to happen. Kind of the general rule is if you got a monitor for anything, you bump it up to mild harm. Okay? And then a near miss and a good catch, and this kind of depends on your culture which one they brand this, right? Near miss implies this idea that you're like, yeah, we dodged that bullet. Hopefully it doesn't go awry next time. Versus a good catch, which is where we identify something before it reaches the patient. So the event occurs. There's many steps along the process of the event, but some safety process or some human being did a great job that day and prevented the problem from getting to the patient. Or we got lucky. Okay? Good on scale of harm. Do we understand that? Do we have any questions? We'll go through an exercise to classify them here in a minute. Okay. Okay. Looking at preventability, this is a complex slide, but I promise you it's more simple than it appears. All right. So we can define harm, but we also need to define, is an event preventable? How preventable is an event? All right. So whenever we look at this, so there's different caveats we have here. So we come out of the gate with if an event happened during a clinical trial. Okay. Clinical trials, they have protocols to follow. We follow it very specifically. It's intended to protect the patient from harm. And so what we'll do is we want to see did we deviate from the protocol? And if we deviated from the protocol and there was an event where harm resulted, then it was preventable. Okay? Because we deviated from the protocol. That's what harms the patient. Okay? The deviations can be purposeful or not purposeful. If there was no deviation, we followed the protocol, then we conclude that it's a complication of the clinical trial or just an adverse outcome, and it was up to chance or systems beyond the individual's control. Now, these next two is where most things live. All right? So most things live in this evidence-based practice use, because just about everything we have has guidelines on it, right? Or at least it feels that way sometimes, especially when you're in an IPT course. And compliance with procedures, policies, and standards of care. Hospitals have robust, and other healthcare institutions have robust policies and procedures, or we have standards of care that we adhere to. That's actually a legal term. Don't know if y'all knew that. Standard of care. You know, what would someone prudent that's in your field or profession do under the same circumstances, right? So if we deviate, then we conclude that it's preventable. If we deviate from evidence-based practice and something bad happens, then this is preventable. Same thing with policies and procedures. Then whenever we go to standard of practice, so standard practice kind of gets a little hairy. It's a little bit different than standards of care. So what we want to do is since the idea is this standard practice, I called it standards of care earlier, I'm sorry. Standard practice, so standards of care are usually documented. Standard practice is that reasonable doubt. Sorry about that. I misspoke. So then we would refer to peer review, because what would someone prudent in your profession do? Best way to do that is get a bunch of people that are from your profession and say, what would you do? And that helps us decide whether it's a complication or adverse outcome or if it is preventable. If their peers can justify that the deviation was under good judgment, then you're good. And then the same thing here, emergency situation where we're doing, the other phrase that I'll call this, so this is the technical legal term, deviation, emergency situation to save life, limb, or function, heroic efforts. Trying to save a person's life at the sacrifice of something else. Okay? Again, we go to peer review, standard of practice, what would be reasonable and prudent. Okay? Questions about this before we move on? Does it make sense? I don't know that the chart does it justice. It's really the only way you can really graph this effectively is a visual, sadly. So it just helps to explain it verbally. If we look at patient safety events in a particular institution, or if we look at them in the whole wide world, we should see a pretty little pyramid. Now, this pyramid assumes that all events are reported. Okay? Hopefully you have the realism and wherewithal to realize that not all events get reported. What are some factors that influence that, do you think? Whether an event gets reported or not. Y'all are working really hard to retain that information from earlier, aren't you? What do you got? Outcome of the event. So we're more likely to report something severe, right? Something bad. Yeah, something bad that happens, something that reaches the patient. We want to make sure that the rest of the institution knows about it, so we're more likely to report that, all right? Not to mention the fact if we don't report it, that looks really bad, right? Looks like you're covering something up or for yourself or for someone else. So yeah, we tend to report that. What other factors may influence whether something gets reported or not? Sure. If you can't tell, you're not sure if the event happened. Did it happen? Did it not? Because you don't see what that documentation looked like. Good. What else influences whether an event gets reported or not? Integrity of the person. That you can't discount that. You can't discount that. There are some people in the world that are more likely to cover something up, and there are some people that are more likely not to. Oh, victory! Okay. After a brief intermission, we've returned to talk about serious safety events. All right, what other reasons? So we identified, let's just recap just a little bit since we got derailed from the technology. So just recapping just a tad. So what are some reasons that an event might not be reported? And one, we've identified two already. So one reason would be that more severe events are more likely to be reported. Integrity of the individual as to whether they report it. What other reasons? What other reasons would an event cause an event to not be, or influence whether an event gets reported or not? What was it? Consequences? Yeah, absolutely. So tell me more about that. Elaborate just a tad by what you mean. Okay, if someone feels that they're going to lose their license or job, they may not want to report it. Okay, so let's unpack that just a little bit more. Okay, So there's the type of event that you do that you are likely to lose your